Well, Leslie, this isn't just about lymphedema care, is it?
It's not, because again, a lot of people associate rehabilitation or cancer rehab with lymphedema care. And that's one part of what we do, but it's a small part of what we do. So I equate this scenario to a bunch of physicians opening a brand new state-of-the-art surgery facility for orthopedics, and they're doing surgeries on all joints, shoulders, backs, necks, knees, ankles. But you bring in this master physical therapist that only treats ankles. So yes, we do see lymphedema, but that's, again, of the frequency of symptoms that we have the power to treat and improve, it's like 15th on the list of frequency.
Well, the reason I bring this up, for about 10 years or more, I ran the multidisciplinary weekly breast cancer conference at my hospital, St. Joseph Hospital in Orange, California. And for the last 3 or 4 years of that, we always had one of your colleagues there. We had a physical therapist there.
Yep.
But as I confessed to you a while ago, I'm a newbie to the area. Frankly, my focus was on making sure we identified patients to be presented at our conference that would be referred on to the physical therapist. But most of it was for sort of an initial evaluation. And then in my head, it was far more about lymphedema than the really big picture of what you and I are going to be discussing.
Yep.
And I think it would be helpful for you to indicate how the referral process works, the team of people. I think it'll be helpful for you to also point out that not all physical therapists may necessarily be, how should we put it, that good in cancer rehabilitation.
Yep, it's definitely a niche practice. Let's take a look.
Okay.
So we are talking today about oncology. So a patient is diagnosed, they spend their time with radiology and pathology. And depending on type of diagnosis and staging, the patient will either have surgery, radiation, chemotherapy, some kind of systemic therapy possibly. And those medical modalities are what lead us to the rehabilitation piece. So the side effect profile of these treatments it's pretty well documented. Okay. So pain, fatigue, and weakness are probably the three most common diagnoses or the three most common complaints of people undergoing cancer treatment. Fatigue is rated by the NCCN as both the most common and the most distressing side effect. And then there's, again, pain, weakness are very common, but again, limited range of motion, scarring and stiffness, different kinds of edemas, bone loss, muscle loss. So chemotherapy-induced weight changes, both negative and positive, happen with some of our cancers. There's balance issues, neuropathies, and then again, depending on the type of treatment, possibly incontinence or sexual function issues. And again, rehabilitation can affect, either prevent, minimize, or eliminate all of these things, or in the case of a neuropathy, we'll do a case study later, but neuropathy, we can't directly impact the amount of sensation somebody feels, but that's sensory, and we can impact the motor function though. So somebody has a lot of neuropathy, they stop moving, all of a sudden they start having balance issues and their legs get weak, and they start to have functional issues. So we can train the functional issues even in the presence of neuropathy. So there's usually always something we can do about this symptom profile. So when it comes to the team, this is what rehabilitation therapists will work on. So I always say the doctors and nurses are going to treat the cancer, and we are going to treat the side effect profile. So if I had to put cancer rehabilitation on one slide, this would be it. So cancer rehabilitation is charged with addressing the musculoskeletal, cardiopulmonary, integumentary, and functional impairments that are expected either from the cancer treatment itself, during treatment, in survivorship, with somebody with stage 4 disease, and at the end of life. So that's really grossly encompassing all of those needs from, again, diagnosis into survivorship. And again, as you mentioned earlier, this is all clearly evidence-based. I mean, good, robust, randomly controlled trials. And so studies have shown that rehabilitation and fitness throughout cancer treatment interventions have been linked to improved outcomes, both for morbidity, side effect-wise, but as we mentioned, it impacts mortality for our people with cancer. And that's hugely important as we move forward, again, both for the patient and for our health systems.
Absolutely.
So here's another one of my favorite quotes. Again, in comparison to other medical modalities for cancer care, cancer rehab is low risk, Okay, low cost, high value. And again, it's evidence-based and it is reimbursable. And so being reimbursed for my patient with cancer as a physical therapist is no different than my colleague who's seeing somebody for a stroke or for somebody who's had a back surgery. So the reimbursements, we're still using the same ICD-10 codes, we're still using the same CPT codes, so it's no different. And again, the support for cancer rehab has been there. This science has been around for a long time. I've been working in cancer rehab for 25 plus years. The oncology section of the American Physical Therapy Association has been around for decades. They're a fantastic group. Support for cancer rehab is there by both the NCCN recommends that rehab begin peri-diagnosis, and both the Commission on Cancer and the NAPBC both have cancer rehab as part of their standards for an accredited program. So it does have its backing.